Good evening, students. So in today's video we are going to discuss one very important clinical syndrome, that is Conn's syndrome, right? We are going to understand the pathophysiology and clinical features of Conn's syndrome, and it's also kind of interesting chain reaction, right? So let's start, right? Conn's syndrome. Now, Conn's syndrome starts specifically from either an adenoma, which is secreting aldosterone, or adrenal hyperplasia. So, two kind of conditions can initiate Conn's syndrome: either an adenoma, right, or adrenal hyperplasia. Right? So any lesion which creates excess of aldosterone can ultimately leads to Conn's syndrome. So where all the aldosterone released from these two kind of entities will eventually act on? It will act on those epithelial sodium channels on the collecting duct, right? So first of all we'll draw our collecting duct, right? And on which channels it is going to act? It will act on our ENaC channels, right? So the aldosterone secreted is going to stimulate the activity of ENaC channels. As we have discussed in our previous video, aldosterone stimulates both. It's going to stimulate both the activity of ENaC channels, and it is also going to stimulate the sodium potassium ATPase pump, right? So it is going to stimulate both. So overall sodium absorption is going to increase. Sodium potassium ATPase pump will be activated, so it will reduce the level of sodium inside that cell, right? And this will increase the gradient for the ENaC channels, and ENaC channels will end up reabsorbing lot more sodium, right? Okay. So it will end up reabsorbing lot more sodium, right? As we have discussed earlier also, wherever sodium goes, the water follows. Wherever sodium goes, water follows, right? If sodium is coming, water is also coming. So what will happen to ECF? Your ECF is going to increase, right? Your ECF is going to increase. If ECF increases, what will happen to our venous return? Our venous return is going to increase, right? If venous return increases, what will happen to end diastolic volume inside the heart? It will increase, right? If end diastolic volume increases, what will happen to stroke volume? It will increase, right? And if stroke volume increases, what will happen to cardiac output? It will also increase, right? And if cardiac output increases, what will happen to blood pressure? It will also increase. So what ultimately we will get is your hypertension. Right? Now this hypertension can lead to many things, right? Which we will discuss one by one, right? One very important thing hypertension can lead to is your headache, right? Just see the chain reaction, one thing leading to another. Now hypertension will lead to headache, right? What else hypertension can lead to? Hypertension can lead to retinopathy, right? retinopathy, right? What else hypertension can lead to? It can lead to left ventricular hypertrophy, right? LVH. And what left ventricular hypertrophy can lead to? It can lead to S4 gallop, prominent S4 sound, right? If you could recall, what is the cause of S4? During atrial systole, the vibration of fibrosed ventricle during atrial systole is the cause of your S4 sound. So if left ventricular hypertrophy happens, right, you will get S4 gallop, right? Right? It can also lead to chronic hypertension, can also lead to fibrosis of heart, right? Fibrosis of heart can lead to what? Atrial fibrillation. I'll write in short form, AF, right? It can also lead to fibrosis of kidney, CKD, right? Which can further lead to albuminuria, right? Albuminuria. Right? Headache. See, so many things can start from hypertension. It can lead to headache, it can lead to retinopathy, it can lead to left ventricular hypertrophy, which can lead to S4 gallop. It can lead to fibrosis of the heart, leading to atrial fibrillation, fibrosis of kidneys, leading to albuminuria, right? Even fibrosis of your vasculature, which can ultimately lead to stroke, right? Fibrosis of vasculature leading to stroke, right? Right? Hypertension can also lead to bruit, right? Due to turbulent flow, right? You can hear this bruit over arteries, right? So many things can happen in case of chronic hypertension. Your headache, your retinopathy, your left ventricular hypertrophy, atrial fibrillation, chronic kidney disease, albuminuria, stroke, and your bruit, right? Now, apart from hypertension, what else can happen? The sodium is going outside. So if any positive ion is moving out, right, what will happen? This side will become positive and this side will become negative. So this side will become negatively charged because positive flux of positive ion is there, right? So this is going to pull in, right? This is going to pull in your potassium ion, right? So a lot of potassium will be exchanged. Sodium will go inside, potassium will be thrown out into the urine, right? And if excess of potassium is thrown out into the urine, what you will get? You will get hypokalemia, right? Now, hypokalemia is something very interesting. If you are following my previous videos, right, you will know that this thing can lead to so many things, right? Like hypokalemia can lead to nephrogenic diabetes. Now, how hypokalemia leads to nephrogenic diabetes? For this, we need to understand that video in which ADH is acting to recruit our aquaporin 2 channels, right? What ADH do? ADH will act on our V2 receptors. V2 receptors will increase the level of adenyl cyclase. Adenyl cyclase will convert ATP to cyclic AMP. Cyclic AMP will increase the level of protein kinase A, and protein kinase A will recruit our aquaporin 2 channels. So this is how ADH works, right? What hypokalemia will do? Hypokalemia will increase the level of prostaglandins. When the prostaglandin level increases, it is going to suppress the level of adenyl cyclase, right? Since the level of adenyl cyclase is suppressed, so ATP won't get converted into cyclic AMP. If the level of cyclic AMP goes down, the level of protein kinase A will also goes down, and you won't have recruitment of aquaporin 2 channel, right? So the action of ADH1B2 receptors will become ineffective. So it will be kind of nephrogenic diabetes insipidus, right? So hypokalemia can lead to nephrogenic diabetes insipidus. Okay, let's take it over here. Nephrogenic diabetes insipidus. Right? Now, what else hypokalemia can lead to? If you're following my previous videos, hypokalemia can also lead to glucose intolerance, right? How hypokalemia leads to glucose intolerance? Suppose there is a cell and outside you have got hypokalemia, and inside you have got normal quantity of potassium, right? So there will be lot more flux of potassium going out from inside the cell, right? Lot more potassium goes from inside the cell to outside the cell. This is our beta cell, right? So a lot more potassium is going outside, right? This is going to create lot of negativity inside and lot of positivity outside, right? And since the cell has become hyperpolarized, right? If the positive charge goes in, we call it depolarization. If the positive charge is continuously going out, we call it hyperpolarization. So since the internal portion of the membrane has become overly negative, right? So even if now the ATP dependent potassium channel closes, right, it won't be able to push the threshold. It won't be able to push this negative charge to that threshold of minus 40 millivolt. Earlier it was easy. It has to go all the way from minus 70 to minus 40. But since it has become overly negative because of increased flux of potassium inside, it will go all the way up to minus 90, right? And from minus 90, it's very tough to come all the way up to minus 40, right? So it will get stuck at minus 60, right? Since it is not coming all the way up to minus 40, your voltage gated calcium ion channels won't open, right? Since the voltage gated calcium ion channels won't open, right? So the calcium won't be able to fuse to your vesicles containing insulin. So insulin won't get released. If insulin won't get released, you will have glucose intolerance. So in one line, if we have to say why exactly hypokalemia causes glucose intolerance, because of hyperpolarization of the membrane of the beta cells, right? So hypokalemia can lead to glucose intolerance, right? What else hypokalemia can lead to? Hypokalemia can lead to polyuria, right? It can lead to polyuria. How it can lead to polyuria? Nephrogenic diabetes insipidus it is leading to. The aquaporin 2 channels are not getting recruited, so water won't be reabsorbed, right? So all that water will go outside in urine. You will get polyuria, right? Right? And you will also get muscular weakness, right? You get muscular weakness both in hyper and hypokalemia, right? That mechanism I discussed in the first video. Muscular weakness. Right? Now, what else can happen in Conn syndrome? Hypokalemia. All that potassium is going outside. So, hypokalemia. But what body will do? Body will try to preserve this potassium. This potassium is very precious ion for the body. So what body will do? It will try to preserve this potassium. It will try to reabsorb this potassium. But in the process of reabsorbing this potassium, it has to excrete out H plus ion, intercalated cells, right? Your aldosterone also directly stimulates the intercalated cells. So it will try to reabsorb potassium, right? But in exchange, it has to excrete out H plus ion. If it excretes out H plus ion, what you will get? Alkalosis, right? Alkalosis. Right? And what alkalosis can lead to in some rare cases? Alkalosis in some rare cases can lead to tetany. Right? If you are following my previous videos, how alkalosis leads to tetany, right? Alkalosis means what? You got less H plus ion inside your body, right? If you got less H plus ion inside your body, the blood will ask for H plus ion from which protein? From albumin. It will ask for H plus ion from albumin, and albumin has got the same binding site for both calcium and hydrogen, right? So if body asks for hydrogen ions from albumin, those sites will become vacant. The extra calcium from blood will come and bind to those sites, and in blood you will get hypocalcemia. Now you will have less calcium for exerting that calcium clamp effect on the sodium ion channel, right? Since there is less calcium for exerting that calcium clamp effect, your sodium ion channel can easily enter via those channels inside the cell, and this will lead to depolarization. Your nerve cells will become hyperexcitable, and these hyperexcitable nerve cells will ultimately lead to tetany, right? Now one very peculiar thing you might have focused on is this thing. ECF is increased, hypertension is increased, hypokalemia, alkalosis. This is almost looks ditto same as which syndrome? Liddle syndrome. This looks very similar, almost same as Liddle syndrome, right? So how you are going to differentiate between these two syndromes, right? How you are going to differentiate between Conn syndrome and Liddle syndrome, right? First thing is cause, right? Liddle syndrome is what? A genetic disease, right? It is a monogenic mutation. And Conn syndrome is what? Conn syndrome arises because of an adenoma, a carcinoma, right? So if something has got a genetic cause, it will show early onset. So Liddle syndrome has got early onset hypertension, right? And Conn syndrome is because of an adenoma, carcinoma. This you get during the later stages, 50 plus, 60 plus, right? So Conn syndrome, you will have late onset hypertension. In Liddle syndrome, you will have early onset hypertension. But then the most critical difference is what? In Conn syndrome, the aldosterone is elevated, right? And in Liddle syndrome, the aldosterone is suppressed, right? But then how you are going to, suppose you are not in position to directly measure aldosterone. If you directly measure aldosterone, the picture is clear, right? In Conn syndrome, the aldosterone is elevated. In Liddle syndrome, the aldosterone is suppressed. Suppose, but without directly measuring aldosterone, right? How you can differentiate between Conn syndrome and Liddle syndrome, right? Now apply your own logic, right? Here the aldosterone is acting on the ENaC channels. The ENaC channels are perfectly normal, right? So if you somehow reduce the quantity of aldosterone, right? Any drug which reduces the quantity of aldosterone will show improvement in Conn's syndrome, right? In Liddle syndrome, the ENaC channels themselves are defective, right? So any drug which changes the quantity of aldosterone won't show any improvement in Liddle syndrome, right? So in Conn syndrome, right, if you give a drug like captopril, right, captopril will be quite effective in Conn's syndrome, but it won't be that much effective in Liddle syndrome. Other thing is showing negative feedback effect, like fludrocortisone suppression test, right? Through negative feedback, if we suppress the level of aldosterone, if we give excess of fludrocortisone, by negative feedback it will reduce the level of ACTH, right? If the level of ACTH is reduced, right, then you will have reduction in level of aldosterone. It will show improvement in Conn's syndrome. So two suppression tests which we do to differentiate between Conn's and Liddle syndrome is captopril suppression test, right? Captopril suppression test and fludrocortisone suppression test. So this is in brief about Conn's syndrome, right? So let's sum it up, right? How Conn's syndrome starts? It starts with an adenoma or adrenal hyperplasia, which is going to secrete excess of aldosterone. This aldosterone is going to act on our ENaC channels. So a lot of sodium will be absorbed and a lot of water will come along with it, right? So ECF volume increases, right? Venous return increases and diastolic volume increases, the stroke volume increases, cardiac output increases, and ultimately our blood pressure increases. Blood pressure can lead to headache, blood pressure can lead to retinopathy, blood pressure can lead to left ventricular hypertrophy, right, and atrial fibrillation, right? Apart from that, you will have hypokalemia, right? This hypokalemia will lead to nephrogenic diabetes insipidus, the mechanism we discussed. This hypokalemia will also lead to glucose intolerance, the mechanism we discussed, and alkalosis, which can in some cases, in some rare cases, lead to tetany, right? One thing very important over here is this can also lead to hypernatremia, right? This hypernatremia will suppress your renin level, right? It will suppress the level of angiotensin 2, aldosterone level will be suppressed. But which aldosterone level will be suppressed? Which is being produced from the adrenal cortex. But if it is being produced from, what to say, your adenoma, that won't be suppressed. So that adenoma is outside the feedback loop of the body, right? So hopefully this is the summary of Conn's syndrome, right? So hopefully this video helped you in understanding the pathophysiology and clinical features of Conn's syndrome, right? Wish you all the very best. Thank you.